Hi, as you've just heard, I'm Kim Piper. I'm the Executive Officer for the Center for Congenital and Inherited Disorders at the Iowa Department of Public Health. And I'm going to talk to you today about a model that we use to do deliberative community engagement for constituent involvement in our newborn screening programming. So a little bit of background about this project, what brought us to here. With regards to the RUSP, the Secretary's recommended universal screening panel, three of the newer disorders on that panel, Pompe, mucopolysaccharidosis type 1, and X-linked adrenal leukodystrophy, those all come with some different characteristics, such as late onset types, potentially higher false positive rates, and treatments with higher cost and potentially some devastating side effects. And those are different than what we might refer to as some of the older conditions that are on our screening panel. So we needed to consider what effects those characteristics would have on the newborn screening program and the newborns in Iowa if we did add those conditions to our newborn screening panel. And we've all felt the urgency or pressure to add new disorders from advocates, families, and even commercial interests. And they have a prominent voice, and they are very vocal and passionate about their recommendations for screening for the disorders that they have a vested interest in. And oftentimes, these folks will go to a sympathetic legislator to get mandatory screening passed for their disorder of interest. And there are only so many public health resources to go around. So how do you decide what is most important or most urgently needs the resources? And then in Iowa, our law mandates that we screen all newborns for all conditions on the screening panel. So there's no opportunity to pick and choose what conditions a baby would be screened for. So hence that brought us to our deliberative community engagement project. Since we know what all the usual players want us to do regarding screening for these disorders, the Iowa Newborn Screening Program leadership wanted to hear from Iowans that weren't directly affected by these disorders and who don't have a direct connection to newborn screening. So the idea was to obtain objective, deliberated recommendations for Iowa's newborn screening processes and screening for new disorders. And we were fortunate enough to receive some funding and technical support from APHL and the new STEPS program there. So what is deliberative community engagement? A definition you can read here, but it's deliberative community engagement is a distinctive approach to involving people in decision making. And it's different from other forms of engagement in that it is about giving participants time to consider and discuss an issue in depth before they come to a considered view. So this differs from, say, town hall meetings or focus groups, and that we specifically give the participants information ahead of time to consider some educational materials, and then they have some time to discuss the issue and develop consensus-based recommendations for that. We had found out about deliberative community engagement from someone, actually Dr. Michelle Gornick, who is quoted on here. And Dr. Gornick had used the model when she was working with veterans and their access to services. She would have deliberative community engagement sessions with individual veterans or groups of veterans about that. So, and then based on a lit review that we did, we found some expertise at the University of California, San Francisco, and Dr. Julie Harris-Way and Dr. Barb Koenig, and they served as our consultants for this project. But a deliberative community engagement can improve the quality of the decision making, and it engages the broad community in the policy development process. And it can also be used to resolve divisive issues and generate discussions about big picture policy issues. And Dr. Gornick has a quote. She says that DCE is possibly the closest that everyday people can get to actually influencing policy. And it's powerful because policymakers receive educated recommendations from their own constituents. So the process that we took to kind of set this up was we published notices in various places across Iowa, community colleges, educational areas, other schools, employers, county health departments, just kind of a wide range of places. There was one point when the project coordinator and myself were even going to do what we called a bar crawl, where we went to a location in the state that we hadn't heard from for participants, potential participants. We were recruiting for high school educated only men. So we thought we would do a bar crawl in this southeast portion of Iowa and put our recruitment posters up in the men's room at these places. But the weather didn't allow us to do that. So, but that was something that we were considering at one point. So we recruited the participants and we gave them a link to register to be considered as a participant. And that also allowed them to provide consent to participate. And then we asked them to complete a demographic survey. We were looking for balance in gender, age, education, religious affiliation, political beliefs, race, and geographic location, especially rural and urban diversity. And we recruited 30 individuals from across the state. 2 ended up dropping out before the date of the in-person event due to family issues. And then on the day of the event, the first day of the event, we had 2 people who were no-shows. And we didn't have an opportunity to reach out to them after that to find out what the reasons were for them not showing up for the event. So we had a 2-day event on a weekend at a hotel centrally located in Iowa. We paid all the expenses for the participants, and we asked them to fill out a pre-event questionnaire, an immediate post-event questionnaire, and a 2-week post-event questionnaire. And they were all the same questions for each of those questionnaire timeframes. And they received an incentive payment for filling out and returning those surveys to us. We also provided them with pre-event educational materials that included a booklet that contained information about newborn screening program and the 3 disorders used for this event that we were using to focus the deliberations on, and that was Pompe, MPS 1, and XALD. And then we also gave them an expert testimony booklet with commentary from various stakeholders in the newborn screening program, such as our state Medicaid director, a representative from the state public transportation agency, because transportation can sometimes be a barrier to access to care. A parent and a son, the son has Pompe disease, our state assistant attorney general, an economics professor, a heritable disease specialist, specifically lysosomal storage disease specialist, an associate professor of genetics who happens to also be the director of an African American cultural project and is the parent of a child with sickle cell disease who had had a stem cell transplant. We had a scientist from the state hygienic laboratory. We had testimony from other states that were screening for these disorders, specifically Missouri and New York. And we had information from the Iowa Newborn Screening Follow-Up Program, the March of Dimes, Association of Public Health Laboratories, 4 local pediatricians, and the state Title V director. So a big group contributed to this expert testimony booklet that we provided to the participants. So the participants were led through facilitated discussion in large group and small groups by trained lead facilitator and small group facilitators. And each small group also had a note taker assigned to those groups. And I can provide more details about how we set this up and how we conducted the event themselves if anybody's interested. But we wanted them to focus their deliberations around 3 questions. Number 1 was, what are important factors to consider when planning for future additions or changes to Iowa's newborn screening panel? Number 2 was, how should the Iowa Department of Public Health make decisions about reporting on new conditions? And then number 3 was, how can IDPH continue engaging the public to provide ongoing feedback for the Iowa newborn screening program? So they deliberated these questions over 2 days worth, or actually 1.5 days of deliberations. And then we recorded all of those small group sessions and the large group sessions. And then the project leadership and our consultants did a qualitative review of the discussions and the comments. So we we sorted through about 32 hours of recording and took notes on all of those. And then we went through and highlighted common themes. So we coded those themes and collated them into specific common themes, as I mentioned, such as provider education and families' access to resources, obtaining consent for newborn screening and things like that. And then we also took comments from participants throughout the course of the event that specifically illustrated a point that we wanted to be heard. And this is just a picture of our coding worksheet. I don't anticipate that anybody can read this, or don't expect anybody to be able to see it, but it's just an example of what we used for coding. So then what did we hear? from these deliberants? What information did they share based on our analysis and review of all the sessions? So what we heard regarding question 1, what are the important factors to consider when planning for future additions or changes to Iowa's newborn screening panel? So what we heard from them was, do not include late onset variants or types in newborn screening. And one of the quotes was, by definition, it shouldn't fall under newborn screen because it's not going to present itself in a newborn. So if it's a late onset, you consider that a late onset. It shouldn't be considered a newborn screen if it's a late onset. And then somebody else said, we're making decisions about this whether we know it or not as parents, is what they were referring to. And even when we know, we all make different decisions to the best of our ability. So they talked about the autonomy and the right to know. And one of the participants said, I would want to know if my child has one of these conditions, whether there's a treatment available or not. And it prepares you, like how much time am I going to have to spend with my child? Some of the other comments that were made was that if the treatments are just going to prolong life, then we shouldn't screen for it. And if the treatment is not accessible by all, do not screen for it. And if there's no treatment, do not screen for it. And the treatment must be proven effective and without high-risk side effects, such as the potential side effects from stem cell transplants. The treatment must be available early and in the newborn period, and we need to consider the risk of genetic discrimination and the impact on insurance and employment with these disorders, and then consider if insurance covers them. So they also spoke to the right for an open future for an affected newborn, that an affected newborn with one of these conditions has the right to the same future as any other child. And then parents have the right to refuse screening. They wanted to make sure that we made that transparent and as easy as possible for families to understand. One of the participants talked about screening for Zellweger disease, which is a variant of XALD. Zellweger disease has a terminal diagnosis, and there are no treatments for that. And they said you wouldn't screen for Zellweger, which is a variant of XALD with a terminal diagnosis. You wouldn't screen for that alone because there's no treatment. And you don't screen for conditions with no treatment, right? And then someone else said, if a child is diagnosed false and begins treatment, you need to consider if that treatment will affect the baby negatively. And the participants' opinions differed as to whether they thought they would want to know if their baby was at risk for a fatal disorder with no treatment available. Some of them wanted to know, and other ones said they wouldn't want to know because that would change how they would treat the baby. There was some discussion about labeling a child through a diagnosis, and then the impact that would have on bonding and how that child is giving opportunities afforded to other children. And again, regarding question 1, what we heard is that we need to really think about what is the purpose for adding these conditions to the newborn screening panel. If we're doing this for research, then we shouldn't be screening just to build a body of cases for research. And then screening should be for the benefit of the public health, not for an individual baby's medical health. We shouldn't screen for the development of treatments or therapies just in order to have an evidence base where we can develop treatments or therapies. And we should consider the impact on reproductive decision making. And regarding that, they said, don't do screening to identify carriers, just to identify carriers. And you need to consider what impact this would have on future pregnancies and know that carriers may be identified and what that might do to the family dynamic. They talked about having resources available. And is this really the best use of public funds or taxpayer dollars? And that's something that you wouldn't really get from an advocate or a commercial interest when you're talking about adding conditions to the panel. But that was something that came out of a constituent-based conversations. And then also they said that we need to consider if this will take away resources from other programs or projects. That came up a few times, so that was kind of interesting that they were recognizing that there are some limited resources, and they wanted to make sure we considered if there was insurance coverage for that, and if this would potentially increase opt-out of the newborn screening program across the board. And then if we screen for these conditions, how would that impact the ability or the political will to screen for other rare disorders? So it's kind of like don't use all your political capital on certain disorders. They thought that genetic counselors should be available to families with an abnormal result. We need to make sure that we have all the data and information that we need in order to make good decisions and determine if the programs are really working. And we need to make sure that the screening program can provide accurate, comprehensive information to families and then help them deal with it if they have a positive result. And make sure that we can provide timely screening for these conditions. And then moving on to question 2, this was kind of the communication question that we had. This was, how should the Iowa Department of Public Health make decisions about reporting on new conditions? How should we change communication to families? And what we heard about this issue was what to communicate to families. And we need to communicate that they can opt out or refuse having their baby screened and explain how to do that, make that clear. We need to fully explain what early onset versus late onset means. And what does that mean for the newborn, and how the newborn screening is not really meant to screen for late onset disorders. We need to remind parents and families that it's a screening test, and babies with an abnormal screen will need further testing and follow-up, and that is not diagnostic. We need to convey that information and data for new disorders might not be as easily definable as those disorders that have been screened for a longer period of time. And then if we're screening for disorders that don't have a treatment, make sure that is known by the parents before the baby is screened. And again, this goes back to their specific recommendation or reference of Zellweger's disease. And then we need to include information about newborn screening and other prenatal information. This was a quote from a participant, like how to give that packet of information to the new mothers after delivery, but then the new mothers are probably stressing about their newborns and don't have time to read the packet. So I think that should be stressed, and having that information be provided several times while I'm pregnant. And then another person said, I think it should be done a couple of times, even if it gets closer to delivery, and then ask if they have any questions, because people are not educated enough at that level. And again, some more feedback regarding communicating with families. Who should communicate with families? They felt that the newborn screening staff should provide the comprehensive newborn screening general information to public and families. And then other providers, such as prenatal care providers, WIC staff, home visitors, prenatal education providers, can all promote newborn screening in their settings. And then disorder-specific information should be given to parents by a trusted or expert healthcare provider. So there was some deliberation about whether they would want to hear information from their child's pediatrician or their child's primary care provider versus hearing it from an expert. So some people wanted to hear it from their baby's provider, the other ones wanted to hear it from an expert. How do we communicate to the families? They were fine with the brochures, but they said that the brochure should be available in different languages and at low reading levels. And then they also said you can use websites and then maybe provide videos in provider offices or waiting rooms or in the lab waiting area while the women are waiting for their glucose tolerance testing and potentially other labs. And then someone recommended providing information through insurers. So a lot of insurers will provide materials to their pregnant members to help guide them and provide information to them about various programming, and that newborn screening should be included as part of that. Regarding communication to providers, some of the things that we heard, and this was pretty loud and clear, was that we need a protocol for providers for how to communicate abnormal results, and then consider providing them a script to do that. So they thought that all providers should be using the same type of information to communicate newborn screening information and results to their parents with. And then a script would be helpful. And then provide fact sheets that the providers can share with the families. And then have a specialist available to discuss abnormal results with the primary care provider before that provider contacts the family, which again was stressed, so that the PCP should have an opportunity to talk to the expert in that condition before they have a conversation with the family. And then regarding communicating newborn screening results to the parents, this is kind of the who, what, when, where, and how of communicating the results. So who should communicate abnormal results? They said it should be the PCP, but with a specialist or someone knowledgeable about the disorder as a backup. And they didn't want the parents to be passed around from provider to provider, expert to provider. And they didn't think that they should have to wait to get further information. So if the PCP was going to give them the initial information about their baby's positive result for a condition, then there better be a specialist available right away that family can talk to. Someone with good communication skills and empathy, and then what should be communicated. What does an abnormal result mean? What is the risk for late onset for that condition? Is treatment started while waiting confirmatory testing? What resources, are available to help family navigate the system or learn factual information about the disorder? And they also said that normal results should either be reported across the board to all of the parents, or the family should be told ahead of time that no news is good news, because a lot of the families don't even know the testing's been done if the results are normal. So they need to know whether they should expect to hear results or not. Where should the communication take place? They all agreed by phone or in person if they need to collect another specimen or do other testing. And this would particularly be important if the baby was still in the hospital. So if they had an abnormal result, then they could collect another specimen before the baby is discharged. When should the results be reported? Well, as soon as possible and emergently if they're time-critical disorders. And then how should the results be reported? And that was with a support person present, if at all possible, with compassion and empathy. Again, don't pass them around from provider to provider or expert to expert. Provide them hard copies of information and use standardized communication or provide the PCP with a script to use. So, and what we heard regarding question 3, so this was the third and last question that we asked the participants to deliberate. And this was, how should the Iowa Department of Public Health continue to involve the public and families in newborn screening programming regarding additions to the newborn screening panel? The deliberative community engagement participants didn't have time to fully discuss and deliberate this question due to weather. So there was a blizzard that came in on the second day. So we were supposed to go till 4 p.m. on the second day, and instead we adjourned at noon so that people could get on the road and get home. The weather was getting kind of ugly. But they did have time over lunch to provide suggestions for ongoing outreach to communities about newborn screening. And those suggestions included annual presentations to county supervisors or county boards of health, communication in the insurance company's mailings to the members, interviews with local media, et cetera, et cetera. And this wasn't necessarily part of the deliberative community engagement process, but it was an interesting dynamic that came from this. We asked the participants to vote on whether they thought we should add Pompe, MPS1, and XALD to the newborn screening panel in Iowa. And we asked them that question 3 different times. So first in their small groups, when they were all broke out into small groups, and then again in the large group at the end of the first day, and then we asked them again at the end of the second day, and then 2 weeks post the event. And these are the results that we got from that vote. Some participants stated that they changed their vote from one time to another, and then others said they voted consistently the same. So for Pompe, it was pretty much a yes, we should add Pompe to our screening panel. MPS1 was a yes, but not as strong as a yes as Pompe is. And then XALD was pretty much a wash. And again, I think this comes back to the Zellweger disease issue. And that was why they would be hesitant to add that to the universal screening panel in Iowa. And then information that we got from deliberative community engagement participant questionnaires. So we sent them the same questionnaire before the event and before we gave them any reading educational materials. And we gave it to them at the end of the event and then 2 weeks post the event. We wanted to see if the responses changed based on the deliberation activities and the educational materials that they received. So they were asked to respond to the different questions on these surveys. 5 was strongly agree, and then down the scale to 1 would be strongly disagree. And there's a sample of some of the questions and the summary score of their responses on these next slides. So this is an example of some of the questions that we asked and what their response scores were pre-event, after the event, and then 2 weeks post-event. So there's really no big surprises on these questions here. the bottom question on the page there, where it talks about, is it worth it to have my baby screened for conditions, even though the test may initially say they have a positive condition when they don't, so a false positive. They were pretty okay with that idea, it looks like, through their scores. So, and as the deliberations went on and the conversations went on, they were okay with that, but they said that families needed to be aware of that possibility before they had their baby screened. They filled these questionnaires out individually, so these weren't filled out as a group. And you can kind of understand the difference in the scores from before they received any education about the event and then the newborn screening and the vote at the end of the first day. But what is interesting to note is a difference in the scores from after the event to 2 weeks post-event. And we were wondering why out loud. The leadership team was, and then some of us thought that maybe it was because they were further removed from the influence of their fellow deliberants 2 weeks post the event, and they were more influenced by the community to which they returned. On this slide, there's a couple of interesting points that I wanted to show you. The second question, I trusted Iowa Department of Public Health to decide which conditions should be on the newborn screening panel. Their summary scores were pretty high for that, so they did believe that that was up to the department to make those decisions. They thought that newborn screening is important, which was great to hear, very high scores in that regard. They also felt like the community members should continue to play an active role in determining the policies for how the newborn screening program determines which conditions it screens. And then the comment about the Iowa Newborn Screening Panel screening for all conditions that are recommended at the national level, that was not as strong of a yes. It was more fair to Midland, if you would, with their thoughts about that. And then the last question on there, the Iowa legislature should decide which conditions are on the Iowa Newborn Screening Panel. That got a definite no or disagree on that point. And granted, these questions are kind of, they're presented in a positive tone or a positive voice, such as, I trust the Iowa Department of Public Health to decide which conditions, instead of, I do not trust the Department of Public Health to decide which conditions. So we understood that that could flavor some of their responses. What do we do with the recommendation? So this is kind of the so what. What changes did we make as a program based on this event and the feedback that we got from participants? We have revised our educational materials. We're going to write them in different languages, expand beyond just the English and Spanish that we have them in now. They'll also be revised to make sure that the reading level is lower and more appropriate for those, especially when English isn't their first language. And then we also are developing or enhancing a picture-only educational brochure. So it's mostly a pictograph that can be used with the other brochures that have text in them by an interpreter to communicate that information to the families in a little easier manner. We did get this QI project approved, or supported by the Association of Public Health Laboratories. Now that we're working on with OB clinics to provide newborn screening education to pregnant women via a wiki website. So we have a newborn screening education website that we've set up, and we're piloting this website and distribution of materials to direct the women to this website for newborn screening education that we hope the OB providers will provide to these women during their prenatal visit. And then we also have a former deliberative community engagement participant serving on our advisory committee subcommittee for management of the Iowa Newborn Screening Panel. And they're there to provide an objective perspective. We chose that participant for the subcommittee based on someone who had expressed an interest in continuing to work with the program and who would not be intimidated by the people who are at the table at these meetings. And that has worked out very well. And then beginning with our spinal muscular atrophy pilot that we started July 1, the education to providers for reporting results to parents includes a fact sheet and suggested script for the providers. And then we are considering a constituent group to provide regular newborn screening programming review. We're not sure what that's going to look like yet, but we are looking into what that might provide for the program. And then some general thoughts. These are kind of my thoughts about the whole process. All the participants took this event and the responsibility within it very seriously. Everyone gave all the topics serious consideration. They came prepared to discuss these, and they all actively participated. There was one who said that they wouldn't do it again, and this person was more reserved and perhaps a little more intimidated by the room. So they were, they were very reluctant to jump in with both feet, if you will. It was really interesting to hear them circle around some of the same issues that we deal with as an international newborn screening community, the things that we deal with all the time. So those ELSI issues that they came up with and discussed after only 2 days worth of deliberation and based on the educational materials and testimony that they heard. So things that they talked about, like we're screening for late onset types, screening for disorders with no treatment, the access to resources, and opting out of the screening. So those are things that we've all struggled with as program staff, but it was interesting to hear them come out with the same questions and deliberation based on only limited information and no experience with newborn screening programming at all before this. And we now have advocates in all the communities that we probably haven't reached before. So all the participants said that they've gone back to their respective communities and have promoted newborn screening. A lot of them said once they got the pre-event materials and had read all the information, they would talk to people within their community about this, their workplace, their family, and just out in their communities. And they were shocked by the lack of awareness of newborn screening. So they were very adamant that we do everything that we can to promote newborn screening. They wanted us to do news interviews and develop PSAs to get out there to raise awareness about newborn screening. And that's the end of my presentation. I'd be happy to talk with you about any questions you might have. Thank you.